Schizophrenia spectrum disorders. Schizophrenia spectrum disorders often develop in early adulthood, and recent estimates suggest that 1% of the global population is affected. Schizophrenia is generally chronic, and most suffer with moderate to severe lifetime impairment. Life expectancy for those with schizophrenia is slightly less than average due to an increased risk for suicide, accidents, and poor self-care. Schizophrenia affects males and females about equally, and it is found in similar rates in all cultures, as opposed to some of the westernized disorders we have covered so far, like anxiety or eating disorders. It is important for mental health professionals to rule out psychosis due to substance use, medications, or other medical conditions. When an individual experiences psychosis due to these other factors, the underlying cause must be treated and is vastly different from schizophrenia. Schizophrenia is best defined as a pervasive type of psychosis characterized by disturbed thought, emotion, and behavior. Individuals may also experience hallucinations and delusions with symptoms related to disorganized speech, disorganized or catatonic behavior, or negative symptoms such as lack of appropriate emotional expression. Schizophrenia symptoms are characterized as positive, negative, and disorganized. Let's examine these in more detail. Positive symptoms. Hallucinations are considered positive symptoms not because they are enjoyable, but because they involve the experience of sensory events without environmental input. For example, individuals may taste something when not actually eating, or have skin sensations when not being touched. Negative symptoms. Negative symptoms for those with schizophrenia are marked by a lack of or insufficient normal behavior. For example, anhedonia is defined by a lack of pleasure, and alogia is defined by a relative absence of speech. Disorganized symptoms. Disorganized symptoms of schizophrenia include confused or abnormal speech, behavior, and emotion. Let's examine other schizophrenia spectrum disorders. These disorders include similar diagnostic criteria to schizophrenia, yet differ in terms of the length that symptoms last. Brief psychotic disorder. Brief psychotic disorder involves psychotic symptoms that last less than a month. Schizophreniform disorder. Schizophreniform disorder is marked by psychotic symptoms that last between 1 and 6 months. Schizoaffective disorder. Schizoaffective disorder includes the symptoms of schizophrenia and major mood episodes, usually depression or mania. Delusional disorder. Delusional disorder lacks most positive and negative symptoms, yet maintains the key feature that an individual experiences delusions that are contrary to reality. It is an extremely rare disorder, and individuals may experience erotomanic, grandiose, jealous, persecutory, and somatic delusions. Catatonia. Catatonia is marked by unusual motor responses and odd mannerisms. Next, let's examine the causes of schizophrenia. Genetics. Schizophrenia has a strong genetic component, and the risk increases with genetic relatedness. Having a twin with schizophrenia correlates with greater risk than having a cousin with schizophrenia. Neurotransmitters. There is also research to suggest that schizophrenia is partially caused by overactive dopamine. This hypothesis is overly simplistic and, although important, many neurotransmitters are likely involved in the development of schizophrenia and related disorders. Brain abnormalities. Individuals with schizophrenia tend to have structural and functional abnormalities in the brain, ranging from enlarged ventricles to less active frontal lobes. Stress. Stress may also activate underlying vulnerability and increase the risk of relapse. Treatments for schizophrenia and related disorders often begin with medication and medical approaches. Antipsychotic medications, also known as neuroleptics, are prescribed to reduce or eliminate positive symptoms. Unfortunately, these powerful drugs have acute and permanent side effects, which can then further impact patient compliance. Psychosocial approaches must be used in tandem for truly effective treatment. Community care programs, social and living skills training, and behavioral family therapy can be especially beneficial to ensure a healthy and normal life for those dealing with functional impairments. Neurodevelopmental disorders are diagnosed first in infancy, childhood, or adolescence. Let's analyze these disorders. Attention Deficit Hyperactivity Disorder. Attention Deficit Hyperactivity Disorder, ADHD, occurs in approximately 5% of school-age children, with the emergence of symptoms around 3 or 4 years of age. It has 3 central features: inattention, overactivity, and impulsivity. These features can contribute to impairments in behavioral, cognitive, social, and academic domains. Symptom types include a predominantly inattentive presentation, predominantly hyperactive and impulsive presentation, and a combined presentation. ADHD tends to run in families and has clear genetic contributions. Neurobiological considerations include smaller brain volume, inactivity of the frontal lobe, and abnormal frontal lobe development. Given these biological contributions, children with ADHD are often viewed negatively by others, and problems can be further exacerbated by negative feedback from peers and adults. Biological treatments, often low-dose stimulants, aim to reduce impulsivity and hyperactivity while improving attention. Behavioral treatment is best achieved through reinforcement programs and parent training. Learning disorders. Learning disorders include academic problems in the areas of reading, mathematics, and/or writing. A diagnosis of a learning disorder can only be met when the problem has persisted for more than 6 months, despite targeted intervention to address lower than expected skills. Roughly 6 million children have been diagnosed in the United States as having a learning disorder, with reading difficulties being among the most common. Genetic and neurobiological contributions are unclear at this point, and it is best to view learning disorders from a psychosocial perspective, rooted in environmental responses to inadequate academic progress. The same goes for treatment aimed at remediating basic problems and targeting specific academic skills. Autism spectrum disorder. Autism spectrum disorder includes pervasive problems in language, socialization, and cognition. It tends to be more commonly diagnosed in males, with roughly 1 in 50 school-age children meeting the criteria. Impairment is seen in areas of communication and social interaction, as well as in restricted or repetitive patterns of behavior, interests, or activities. This label is new to the DSM-5, as it encompasses several disorders previously classified as pervasive developmental disorders. It includes autistic disorder, Asperger's disorder, childhood disintegrative disorder, and Rett syndrome. Historical views of autism include failed parenting, lack of self-awareness, and behavioral correlates like self-injury. Modern research now suggests that there is a significant genetic component involving numerous genes on several chromosomes. Also, individuals with autism tend to have a larger amygdala at birth, which mediates the way stress in the environment is interpreted, as well as lower levels of the neurotransmitter oxytocin. It is important to note that large-scale public health studies do not support the stance that vaccinations increase the risk of autism. At one time in recent medical history, it was thought that mercury in some vaccinations increased autism risk. However, there is no evidence to support this. Treatment for autism spectrum disorder is heavily psychosocial, and early intervention is crucial. Behavioral approaches focus on building skills, reducing problem behaviors, and providing communication and language training. Intellectual disability. Intellectual disability, ID, first evident in childhood, involves below-average intellectual and adaptive functioning, leading to difficulties in conceptual, social, and practical domains. The range of impairment varies greatly for each individual with this diagnosis. In previous diagnostic manuals, ID was broken down into levels of severity based on IQ. The DSM-5 no longer uses this framework, but an individual diagnosed with ID typically has an IQ below 70 to 75. There are many known causes of ID, too many to fully list here. Some examples include fetal alcohol syndrome, exposure to illness in the womb, malnutrition, head injuries, and child abuse. There are also genetic influences. For example, Down syndrome is the result of an abnormality on the 21st chromosome. ID can also be the result of multiple random genetic mutations in the early stages of life. Treatment approaches for ID range from those provided for individuals with autism to those provided for individuals with learning disorders. The goals are similar for all individuals with ID, ensuring basic, social, and practical skills so that individuals can live a happy, healthy, and fulfilling life. Communication and motor disorders. Communication and motor disorders include childhood onset fluency disorder, also known as stuttering, and language disorder that involves limited speech in all situations, despite the fact that understanding of speech is normal. Social, pragmatic communication disorder is defined by difficulty with social aspects of communication and lacks the other basic features of autism. Tourette's disorder involves involuntary motor movements and vocalizations. Neurocognitive disorders generally develop later in life and affect learning, memory, and consciousness. They involve broad impairments in cognitive functioning, often resulting in profound changes in behavior and personality. Let's examine the three main classes of neurocognitive disorders and their treatment. Delirium. Delirium is defined by the central features of impaired consciousness and cognition. Individuals with delirium appear confused, disoriented, and inattentive, while also experiencing marked memory and language deficits, all over a short period of time. Full recovery is possible within several weeks, and this condition is more prevalent in older adults or individuals undergoing medical procedures. Dementia, drug intoxication, infections, and sleep deprivation are all medical conditions related to delirium. Treatment is best achieved by addressing precipitating medical problems and providing reassurance and comfort to those affected. Major and mild neurocognitive disorders. Major and mild neurocognitive disorders now subsume the previous diagnosis of dementia. Those with mild neurocognitive disorder are experiencing the early stages of cognitive decline and can function independently for most, with some accommodations. Major neurocognitive disorder involves a significant cognitive deficit and evidence of interference with daily independent activities. During the initial stages, individuals may experience memory and visual impairment beyond what would be considered baseline. Other symptoms can include delusions, apathy, depression, agitation, and aggression. Neurocognitive disorder due to Alzheimer's disease accounts for nearly half of the large neurocognitive disorders category. Clinical features include memory, orientation, judgment, and reasoning deficits. Amnesia. Amnesia, previously diagnosed as amnestic disorder, is now considered a type of neurocognitive disorder. Individuals with amnesia may be unable to learn new information or recall previous information while experiencing no other loss of high-level cognitive functions. Other causes of neurocognitive disorders include Parkinson's disease, HIV, Huntington's disease, Pick's disease, and other rare neurological conditions. The causes of neurocognitive disorders are vast. Structural abnormalities in the brain, genes on several different chromosomes, and lifestyle factors. Treatment. Treatment is often aimed at primary medical causes and slowing the progression of deterioration. Psychosocial treatment approaches are designed to enhance the lives of individuals and their families, to teach compensatory skills, and even